Welcome back. Good evening. I think you had a good break so that we are going to start from where we left already. I have a good number of cases also to be discussed later on in the later part of the session. So that because we only scratched the part of ABG and we have a lot of things to do in this. So we have discussed the basic things, the basic rules we know. Now we know what are the different parts of the ABG, and we know the anion gap, and we know what is delta-delta ratio, we know what is urinary anion gap. So since we know all these things right now, it's better to move on to the next stage of understanding ABG. That is go into metabolic acidosis, respiratory acidosis, metabolic alkalosis, and respiratory alkalosis sort of cause. As far as metabolic acidosis is concerned, first we know there is something called a high ion gap metabolic acidosis, then we have a low ion gap metabolic acidosis. So how you're going to approach a patient with a high ion gap or a probably low ion gap metabolic acidosis. That's what we're going to see in this particular setting. So first see the anion gap whenever the patient is having metabolic acidosis. So I'm going to see whether it's a increased or if it's a normal. If it's high ion gap metabolic acidosis, I'm going to, if anion gap is high, I will call HAGMA, and anion gap is normal, then I'll be calling it as NAGMA. So then the next step in approaching a HAGMA is to find out what is the cause of a HAGMA. So now in this situation, I'll be seeing the ketone bodies first. See the ketones, whether it is positive or negative. So if ketones are positive, then probably think about diabetic ketoacidosis or probably alcoholism or probably starvation, which I've told you already. If ketone bodies are negative, so rule out two important causes, that is lactic acidosis and uremia. So in this setting, I can see lactate and I can see serum creatinine. So if etiology is found, so it could be either a lactic acidosis. Lactic acidosis have a tremendous amount of etiology, like in the form of sepsis. Even metformin can induce a sort of lactic acidosis, even though it is very rare. And or it could be uremia. So usually whenever uremia producing HAGMA means it indicates a late stage of renal failure. It's a late kidney failure. So it's not early. So now, if serum lactate is normal and serum creatinine is also normal, you don't have any other problem here. So then in this setting, you can think about a toxicology screen. Because it must be usually due to toxins like probably salicylic acid, probably ethanol, methanol, and all this stuff you have to see. So here you're going to do the toxicology. How to approach further, I'll discuss later on once I finish off the entire ABG session. Then once you go to the NAGMA, non-ion gap metabolic acidosis. So here my idea is to find out the urinary anion gap first. Suppose if my urinary anion gap is positive or urinary anion gap is negative. If urinary anion gap is positive, I know it's going to be one of the renal causes that we're talking about. If urinary anion gap is negative, then I can think about a GIT cause, which means it's a negative gut cause. The most important is the diarrhea, but remember proximal artery is one cause. Proximal renal tubular acidosis is one cause that can result in both positive as well as a negative urinary anion gap. So that's all. This is how I'm going to approach a patient with a metabolic acidosis. And please do understand the fact that whenever the patient is having a HAGMA, one more important thing that I need to do is the delta-delta ratio. Don't forget that. If delta-delta ratio is less than 1, then I can be sure that the patient is having associated NAGMA. The delta-delta ratio is more than 2, then I can tell that the patient is having associated metabolic alkalosis because of some other etiology also. So this is very important to understand from clinical perspective. So which we have discussed already. So this is a simplified approach to go for a metabolic acidosis depending on the anion gap. Now we know what are the cause of non-ion gap metabolic acidosis, what are the cause of high ion gap metabolic acidosis. But more importantly, now we have not discussed about this one particular entity which we need to discuss, that is renal tubular acidosis, which is a very important thing to discuss in the first place, because I mean, this is the right time because you know about the acid-base balance currently. So it's going to be little simple if we discuss right now. Otherwise, if you lose this, then you will not be able to discuss later on. So we know there are two types of acid. I mean, RTA, one is called a proximal renal tubular acidosis. Second one is a distal renal tubular acidosis. remember, first of all, the most important thing is that these are tubular disorders. Remember, renal tubular acidosis means these are purely tubular disorders. And many of the times they tend to have a normal serum creatinine, which means in the presence of excess serum creatinine, you cannot be sure that this acidosis is due to renal failure or due to tubular defect. So that is why whenever you take a nephrology textbook or discuss with any nephrologist for that matters, they'll be clearly telling tubular disorders cannot be found out if you have a higher creatinine. Especially this kind of renal tubular acidosis is very difficult to find in case if you're having a higher serum creatinine, or if you're having renal failure, you cannot find out because RTA typically produces a NAGMA. If there is an associated renal failure, they will become a HAGMA. Very difficult to find out. So there will be a mixture of findings. Similarly, renal failure itself will induce a lot of other changes, which is not very typical of a renal tubular acidosis. So I'm not telling renal tubular acidosis will not be there in the setting of a renal failure, but in the setting of a renal failure, it's very difficult to comment on some tubular issues. That's why there are some constant standard things that textbooks mention. Whenever you want to diagnose an RTA, usually the patient will have a normal blood pressure, the patient will have a normal serum creatinine. Remember, this is only a classic scenario, but not always. Normal serum creatinine, most of the times the patient will have common features like hypokalemia, and patients also will have a normal and gap metabolic acidosis. These are the four things that are very classical in any renal tubular acidosis, especially the proximal versus distal RTA. Only in these scenarios, it's possible to suspect renal tubular acidosis. Suppose if the patient is having severe hypertension, I cannot really suspect renal tubular acidosis in that setting because the hypokalemia can be due to hyperaldosteronism causing hypertension and hypokalemia. So I cannot really predict that. So this is a classic scenario, perfect scenario where you can tell the patient is having a renal tubular acidosis. But before going on to renal tubular acidosis, you want to know how they are classified. So basically, I tend to classify renal tubular acidosis as a hypokalemic RTA and a hyperkalemic RTA. Hypokalemic RTA can be further divided into a proximal or type 1 or type 2 RTA. Sorry, proximal or type 2 RTA, and we have a distal or a type 1 RTA. I don't know who named like that proximal as type 2 and distal as type 1, but nevertheless, proximal is called as type 2 RTA and distal is called as a type 1 RTA, as well as hyperkalemic RTA is concerned, it's called as a type 4 RTA. I'll tell you what is the reason for hyperkalemic RTA right now, but our understanding should be first very correct on the proximal type 2 and distal type 1 RTA. So I can write in bracket proximal is type 2 renal tubular acidosis and distal is type 1 renal tubular acidosis. Before going on to the actual problems, actual causes and etiology that causes proximal and distal, let us see the basic phenomenon that happens in proximal and distal. So now I'm going to draw the distal nephron here, and I've drawn the proximal nephron here. This is afferent arteriole, this is the efferent arteriole. So now you know what are the things that are going to happen. First thing, the proximal nephron, the most important aspect of proximal nephron that is affected in the setting of a proximal RTA is the ability to reclaim bicarbonate. So that's the most important thing that is affected. Remember, RTA is not like many students think that there's a damage to the proximal nephron. So if there's a damage to the proximal nephron, that I'll call it as an acute kidney injury. So that's not the case here. The selected functions of the tubules will be lost. So that is the idea here. It's not like the tubule is damaged, tubule is gone. So then it will be an acute tubular necrosis for that matter. So we're not talking about that. The selected functions, it's a functional problem of the tubules. Some of the selected functions of the tubule might be lost. So the most important thing that is affected as far as the proximal RTA concerned is the bicarbonate reclamation. This is the one thing that is typically affected in the setting of a proximal renal tubular acidosis. So what is going to happen is this patient is going to have an increased urinary bicarbonate. And that's really important point. So that is why majority times the fractional excretion of bicarbonate is what we see. So when you see the fractional excretion of bicarbonate in this patient, it will be usually more than 15. And that's one important sign of a, like proximal RTA. So nevertheless, the bicarbonate loss is the basic definition of a proximal renal tubular acidosis. But remember, proximal tubule has some other functions as well. For example, there is another function I told you that is 1-alpha hydroxylase function. Everyone knows what this 1-alpha hydroxylase is going to do. This is going to result in production of calcitriol, active vitamin D. I'm not telling always. Sometimes this function may be lost. And another function that proximal tubule does is solute reabsorption. Solute reabsorption. So what about the solute reabsorption in this scenario? as far as the solute reabsorption is concerned, the most important things that we are talking is the sodium. Of course, sodium is getting absorbed, but proximal nephron absorbs the solutes along with the sodium. For example, you are studying some transporters like sodium phosphate transporter will be there. Then you have sodium glucose transporter called as SGLT2. That is very important for the kidneys. Then you have sodium amino acid transporter. Sometimes what can happen is these functions also may be affected. Suppose if these functions also affected, I mean, remember, this may or may not be affected. I'm not telling that they should be affected. I'm telling the most important function that is affected is the bicarbonate reclamation function. So that is the most important function that will be affected in this setting. Suppose if the other functions are also affected. So it's not only about the bicarbonate loss. If the other functions are also affected, for example, if the patient is having glycosuria because of the proximal artery, and the patient is having amino aciduria, and the patient is also having phosphaturia. So along with the bicarbonaturia, if the patient is having this is what we refer to as something called a Fanconi syndrome. Remember, it is not Fanconi anemia, it is a bone marrow failure syndrome. We're talking about a Fanconi syndrome. So if you have associated, but remember, majority of the cases may have only bicarbonaturia without any Fanconi syndrome. So this is the basic criteria to tell it is a proximal artery, that is bicarbonaturia. But the patient may have an associated Fanconi syndrome. And few patients may also have associated calcitriol defect also, because they may not produce sufficient amount of 1-alpha hydroxylase. So they might be having a low active vitamin D state in the body. Whenever they will have a low active vitamin D state, they might have a lower calcium and a lower phosphate because of that. So remember, the low phosphate can be due to either this vitamin D problem or this phosphaturia, that is losing phosphate in the urine. That may also can result in low phosphate in the blood. So nevertheless, this low calcium, low phosphate, and low vitamin D is always a problem for the bone, because they will rapidly result in osteomalacia. In many cases can have an associated bone problem like osteomalacia also. It's very classic. Whatever I told you are very classic of a proximal artery. Remember, because the bicarbonate is not getting absorbed, the serum bicarbonate will be basically low. It will be decreased. But remember, serum bicarbonate decrease will not be that great, because the proximal tubule only handles the bicarbonate in the form of reclaiming the bicarbonate. But nevertheless, the distal nephron, if it's intact, even in the presence of a proximal artery, the distal nephron can produce new bicarbonate and they can compensate for this lost bicarbonate. So which means a low serum bicarbonate will be less severe. It will not be more severe. Low serum bicarbonate will be less severe in this setting. So if less severe means, usually it will be in the range of somewhere around 12 to 20. So this will be the serum bicarbonate range. It's normal is around 24. We know that. So 20 to 28 is normal. 24 is average. So usually it will be less severe acidosis, in the sense like it will be in the range of 12 to 20. And we know, because the bicarbonate is low, and that's the primary problem here, this is going to result in something called a NAGMA, that is normal and gap metabolic acidosis. I told you here there is no excess organic anions that is there. It's a pure loss of bicarbonate. Because of that, your H+ is relatively increasing. That's why you're getting an acidosis, and that is what we refer to as a normal anion gap metabolic acidosis, otherwise referred to as a hyperchloremic metabolic acidosis. We have studied already all these principles. Okay, now one more important thing. So if you ask this patient's having hypokalemia, because we explained that this patient is having a NAGMA, and we have not yet explained why these patients are having a hypokalemia. So why these patients are having hypokalemia? Can anyone explain why these patients are having hypokalemia? Anyone? I'm seeing your answers, looking for your answers. Anyone can explain why the patient is having a hypokalemia? I'm getting different answers. Acidosis pushes potassium inside, compensation for sodium loss at ENaC, membrane osmolality, more sodium goes to distal. But none of them is right, because the amount of sodium they lose, they do have a little bit of sodium loss, of course, yes, but the amount of sodium loss that these patients are having is quite less, and this is the only pump that is lost. And I don't think because you have the thick ascending limb, which is a joint which can take care of the sodium loss. I don't think sodium loss is going to be the major reason. Decrease reabsorption at the PCT, no. Again, no, that's not the reason. Acidosis push potassium inside. I told you acidosis is mild in this patient, and that amount of acidosis, I don't think it will be serious enough to push the potassium into the cell, causing intracellular shift. The answer is there in your previous diagram itself, which I have drawn very clearly. Yes. So these patients are known to have bicarbonaturia. They are going to have too much of bicarbonate in the urine. So bicarbonaturia. So this bicarbonaturia is going to increase the negative charges in the distal part of the nephron. Once you increase this negative charge, I told you the movement of sodium inside produces negative charges, and that's the thing that pulls the potassium out. The same thing happens here because bicarbonaturia is going to create a lot of negative charges on the luminal surface, on the apical surface. Now potassium will be pulled out by this bicarbonate. So because of the severe bicarbonaturia they have. So that is the reason why proximal RTA patients are having bicarbonaturia. Hypokalemia. So now that explains hypokalemia. So I can tell the reason for hypokalemia is the bicarbonaturia, which means this is going to increase the urinary potassium loss. And that is the reason for the development of hypokalemia in these patients with proximal renal tubular acidosis. Fine. So that's all. So now we have explained everything. Bicarbonaturia, what is Fanconi, why you get osteomalacia, why you get hypokalemia, and why you develop normal and gap metabolic acidosis. All these things can be easily explained in a proximal RTA. Because in therapy, I'll tell you one more point, that time it becomes really important. So now, after understanding this principle, one more thing to understand is the pH of the urine. So what will be the urinary pH? The urinary pH, it's a reflex response by many students to tell that urinary pH will be alkaline. That's what the reflex response, as far as many students are concerned, that's what they will tell usually to me the moment I ask what is the urinary pH, because they believe that because there is so much of bicarbonate in the urine, there's so much of bicarbonate in the urine, you will result in an alkaline urine. But remember the fact that the pH, urinary pH of the pH of the urine, the urinary pH is actually decided by the distal nephron. That's why the basic understanding of the subject is very important. Where I told you in the beginning itself, the urinary acidification is a primary function of the distal nephron. If the distal nephron is okay, especially in the setting of acidosis, if the patient is having an acidosis, this distal nephron is going to increase the H+ secretion. If the patient has increased H+ secretion, of course, this increased H+ in the distal nephron is the main reason why the the urine is acidified in the first place. So this can make an acidic urine, which means the pH of the urine can be acidic in a proximal RTA. Remember, the urinary pH is alkaline only in early stages when the patient is not having acidosis. But once the patient develops acidosis in a proximal RTA, surely you will get a acidic urine, which means the urinary pH will be less than 5.3 in this particular setting. That's the take-home point. So suppose if you're having a clinical acidosis and the patient is coming with a proximal RTA and having a clinical acidosis, patient will be having a low urinary pH. That is because of the distal nephron's intact ability to acidify the urine, which is the most important, because proximal nephron cannot acidify the urine. I told you multiple times. The distal nephron is the one that is a high gradient pump that is going to acidify the urine in the first place. So they can acidify. pH can be less than 5.3, but in very early stages where there is no change in the acidosis status that much, bicarbonate status that much, in that particular setting, because of the too much loss of bicarbonate, your urine might be alkaline. But typically when they're present with acidosis, urine will be acidic only. That's a very important point once again. So now moving on to the etiology. So now let us see what will be the etiology of proximal RTA. As far as the etiology is concerned, we have two types of etiology. One is called primary etiology, where we don't know the idiopathic. So usually whenever there is a primary etiology, it is idiopathic, means many times they will have a Fanconi association, primary Fanconi association, which means there will be a glycosuria, amino aciduria, and all this stuff. So primary idiopathic is what we refer to as Fanconi syndrome, and they'll have associated glycosuria, amino aciduria, and phosphaturia. That's the most important thing. So or the etiology can be acquired etiology. Primary etiology can be due to some other thing also. For example, some congenital conditions. So to understand what are the congenital conditions, examples that produces Fanconi syndrome sort of a thing, you can understand that Fanconi, I remember by the name Fancy. Fancy means Fanconi, which means some fancy causes. So as far as I'm concerned, what is the fancy cause? Wilson, if I write, like that looks fancy for me. So I think it's a fancy cause. Then if I like cystinuria or cystinosis, I believe that's a fancy cause. So that's something different. Or if I take a word called galactosemia, for that looks very fancy for me. So these kind of congenital conditions, fancy conditions, cystinosis, then hereditary fructosemia, like all these are very fancy causes in the sense like we don't encounter very common in our clinical practice. That's why a lot of congenital and fancy conditions will produce a proximal RTA instead of a distal RTA. Typically, they produce a Fanconi type of syndrome. As far as acquired causes are concerned, they may or may not cause Fanconi kind of a picture. I'm not telling no. So, but what are the acquired causes? So typically acquired causes can be divided into two. One is drug-related causes and non-drug-related causes. Drugs are very important. By far, the drugs are the commonest cause of developing proximal RTA in the world. Number one is astazolamide. It's a no-brainer. Astazolamide, even though they do not cause Fanconi syndrome-like picture, they are going to cause bicarbonaturia because they are going to block the bicarbonate reclamation, the basic mechanism of action of astazolamide in the first place. So astazolamide is a no-brainer. Definitely, they can cause your Fanconi. Then second drug that can produce this kind of picture is aminoglycosides. Very, very important. Aminoglycosides can produce acidosis and proximal RTA like a kind of a picture. And you have certain other drugs. The most important of those is TDF, that is tenofovir disoproxil fumarate, or any form of tenofovir for that matters. Tenofovir is a very, very good drug, excellent drug, and this is a very important question, man. Absolutely important question for exam. You can never afford to forget this question. Tenofovir. Tenofovir is because it's an excellent drug in the setting of your HIV, in the setting of HBV. In fact, if somebody asks you what is the only drug which hepatitis B virus have not shown any resistance till date, answer is tenofovir. They have not shown any resistance. Your hepatitis B virus till date. In HIV, it's also a very good drug. It's safe in pregnancy. Choice of drug in HIV as well as HBV in pregnancy is again tenofovir only. Such a good drug in these viral conditions. But the problem is it's nephrotoxic, which is basically a dose-dependent kind of a nephrotoxicity. So we have two drugs. One is tenofovir disoproxil fumarate, and second we have something called a tenofovir alafenamide. Basically, we have two drugs are there. So initially we had TDF only. If you take even now the common NACO regimes that are given in government hospitals, even in private hospitals, it will be TDF only. That's tenofovir disoproxil fumarate. The dose is 300 milligram. At a dose of 300 milligram, this drug is known to produce some incidence of nephrotoxicity. Like they can elevate the creatinine, they can produce a proximal RTA kind of a picture, they can produce osteomalacia because proximal RTA will result in development of osteomalacia and bone problems. So people who develop this nephrotoxicity because of tenofovir, because even though this drug is wonderful drug, has a very good side effect profile. I mean, basic overall side effect profile for the body is very good for tenofovir. This, nephrotoxic potential alone is one reason why you have to sadly discontinue this drug from many patients. So to avoid that only, we had a tenofovir alafenamide. Because I told you tenofovir related nephrotoxicity is dose dependent, which has to be given in 300 milligram. They have created a prodrug. Prodrug in the sense they will be metabolized very slowly for a longer period of time. So they discovered this drug alafenamide, which is given a dose of only 25 milligram, which is much less nephrotoxic compared to that of tenofovir disoproxil fumarate. So that is the reason why currently we have two drugs. Patients who are prone for nephrotoxicity or patients who have already developed nephrotoxicity, then tenofovir alafenamide, which is given at a much lower dose, is a option because I told you tenofovir related nephrotoxicity is basically dose dependent. More tenofovir you give, more is the problem. Alafenamide being a prodrug, it's given at a much lesser dose. So the nephrotoxicity risk is much, much lesser. In fact, almost 10 times lesser compared to that of tenofovir disoproxil fumarate. So that is why we have two drugs. If you go and see the pharmacology textbooks properly, there will be two drugs, alafenamide and disoproxil fumarate. Disoproxil fumarate is the problem. Alafenamide has lesser issues. Tenofovir is a very important drug, very commonly asked question in exam. So you need to know that. Then apart from that, you can get with cisplatin, platinum group of compounds. Then there is a drug called ifosfamide, which is a congener of cyclophosphamide. Even that might be extremely important in causing this kind of proximal RTA, and topiramate. this is an anti-epileptic drug which can be nephrotoxic. We have studied already in the AED section in the CNS. So these are the drugs that are known to produce proximal RTA kind of scenario. The most important of all being the tenofovir. That's the most important, the exam point. And as the other acquired causes are concerned, you can develop amyloidosis. Amyloidosis can produce that. Amyloidosis in the sense you can remember another cause simultaneously, that is paraproteinemia. In the sense multiple myeloma, monoclonal gammopathy. So they can produce, because amyloidosis can produce both proximal and distal. I'll tell you how, but proximal is quite common because of the direct amyloid deposition of the proximal tubule. They can result in this kind of a proximal RTA kind of a scenario. Then you can get with heavy metals. These are very important. Old questions, heavy metals like lead, iron, mercury, copper, if it's in excess, they can produce this kind of proximal RTA kind of a scenario. Then you can get in paroxysmal nocturnal hemoglobinuria, PNH. PNH can produce because of the hemoglobinuria that they are getting. And renal transplant individuals, post-renal transplant individuals can develop proximal RTA kind of scenario because of the immune damage. In that, usual question exam will be heavy metals and PNH. Other things they won't ask. Remember, if you want to know only 3 causes among all these things, remember only heavy metals, PNH and tenofovir. Just 3 causes if you want to know for example. Because acetazolamide is something nonsensical, like it's something straightforward. That is nothing to be, like mugged up. So if you want to know for exams, just remember these 3 causes and go for exams. One of the causes will be there if at all they want to ask a question from a proximal RTA. That's it. So that's all. We completed the proximal RTA understanding in a very detailed way. Now moving on to the distal renal tubular acidosis, that's type 1 distal RTA. As far as type 1 is concerned, the problem here is the H plus cannot be secreted. So that is the main problem here. So H plus, the main problem, H plus means, I told you the functionality of the tubule is lost in secreting H plus. We know there are 2 ways where you can secrete the H plus. One is this H plus ATPase. So that is going to secrete H plus. So second problem is like this K plus H plus ATPase, which you're talking about. K plus H plus ATPase. Even that is also going to secrete H plus. And as far as the distal RTA is concerned, the main function that is lost is the H plus excretion. So both this will take a huge hit. K plus H plus ATPase as well as the H plus ATPase. So in this setting, what's going to happen? You are going to retain a lot of H plus. So much of H plus is retained in the body. So this is going to result in NAGMA, that is Norman gap metabolic acidosis. And at the same time, you know that you cannot reabsorb potassium as well, because this potassium H plus ATPase is also something that is integrated with the H plus secretion. So since this cannot be lost, this cannot be reabsorbed, so you're going to have a urinary potassium loss. And because of that, you will result in hypokalemia. Of course, the acidosis will be severe in the setting of distal RTA, and of course the hypokalemia also will be severe in the setting of a distal RTA. It's quite understandable. Once the acidosis becomes severe due to a lot of other issues, ultimately your hypokalemia is also going to become severe for sure. So there's no doubt about that. So hypokalemia and normal gap metabolic acidosis both tends to be relatively severe, because the distal nephron is the one that is important for the potassium homeostasis as well. I told you previously itself, when we started in the first itself, we discussed that distal nephron's ability. Distal nephron is the most important for the potassium homeostasis. So once that is gone, and if they cannot reabsorb sufficient potassium, it will result in a serious hypokalemia. So that is why they're going to cause severe hypokalemia compared to that of the proximal RTA. So NAGMA and hypokalemia both will be severe. So hence proved. But there are some things that have to be understood. And these patients are more prone for urinary stone formation, especially nephrolithiasis. This is one important finding that will be very regularly asked in exam. So now the question really comes, why nephrolithiasis in these patients? For that, you have to answer. The reason for that is increased urinary calcium. These patients are having high urinary levels of free calcium. And that is why these patients are having nephrocalcinosis. Now the question will come, why high urinary calcium and why you get a nephrocalcinosis? This has a lot of hypotheses. We don't know why. But one important direct evidence why you have a high urinary calcium is because you have a low urinary citrate. So hypocitraturia. So this low urinary citrate and hypocitraturia is the one that is thought to be the main reason for development of hypercalciuria, which subsequently results in nephrolithiasis or renal stones over a period of time. Nephrolithiasis, if it is long standing, because of many stone formation, they can go for a picture called nephrocalcinosis also. That is too much stone formation in the kidney, nephrocalcinosis. Too much stone formation, nephrocalcinosis. Clear. Now the question will come, why you should have a low citrate? Like low citrate. And it's been assumed that this increased H+, this is the only accepted hypothesis as of now, this increased H+ in the distal nephron actually is going to affect the mitochondrial function. So this is the direct evidence that we have right now. So reduced mitochondrial function. Because of reduced mitochondrial function, there will be a reduced TCA cycle in the distal part of the nephron. So there will be a reduced TCA cycle, that citric acid cycle. Because of that, they produce a reduced citrate. And because of that only you have hypocitraturia. So this is the only evidence that we have right now, that acidosis that is severe, and if the cells accumulate acid and they will have a mitochondrial dysfunction, because of mitochondrial dysfunction, citric acid cycle is affected. Because of that, low citrate is produced. Because of that only, low citrate is getting eliminated. And is citrate really important? Yes, citrate in the urine is very important, because whenever they eliminate H+, this distal nephrons, they also eliminate citrate side by side. Once they eliminate citrate, like what's going to happen is this citrate is the main thing that chelates the calcium. So they are the ones that combine with the calcium and prevents the free calcium from forming and precipitating in the urine and forming nephrocalcinosis. That is why low citrate is the main reason for increased free calcium. Increased free calcium is the main reason for getting nephrolithiasis. And this is typically going to happen in the setting of a distal RTA. Very important point. This is not a finding of a proximal RTA by any means. Now, what about the urinary pH? What about the urinary pH? So the urinary pH will always almost be alkaline in distal RTA, because to acidify the urine, the one important thing that you need is the distal nephron. If distal nephron is not there, you cannot acidify the urine at any cost. It's not possible to acidify the urine. So urine will remain alkaline. By definition, urine pH will remain more than 5.3. Or some books will get 5.5, some books will get 6 as a cutoff, so it doesn't matter. So urinary pH will, no matter what, urinary pH will always be alkaline. Suppose if it is severe, means what I'm trying to tell, I told you acidosis will be severe, isn't it? The normal and gap metabolic acidosis will be more severe in the setting of a distal renal tubular acidosis. So which means the serum bicarbonate usually will be less than 10 in this setting. Very severe. In proximal RTA, we saw somewhere around 12 to 20, average will be 15. Here it will be less than 10, usually around 5, 4, very severe reduction of the bicarbonate. And urine will always be alkaline, despite the fact that the blood is acidic. Remember, that's violating the physiology. You know very well, when you drink more water, you have to pee more water. When you eat more sodium, you have to pee more sodium. That is simple homeostasis. When you eat more potassium, you have to pee more potassium. This is a simple logic behind the homeostasis mechanism that is happening. Similarly, if you drink more acid, you should pee more acid. If the blood is having more acid, and if you don't pee more acid, and if the urine is alkaline, then which means there is something seriously wrong. So which means the distal tubule is at fault, and that's why acidic blood with an alkaline urine in the presence of nephrocalcinosis in exam always goes towards a distal renal tubular acidosis. There is no doubt about that. That's the only thing that can fit into this particular kind of a picture. And now if you still have a doubt, sir, I still have a doubt whether it is a proximal RTA or distal RTA, because you told in the early stage of distal RTA, proximal RTA, I can see an alkaline urine. So see the fractional excretion of bicarbonate. So here fractional excretion of bicarbonate is going to more than 15. Of course, in distal RTA, the fractional excretion of bicarbonate is not going to be that much, because it's not a problem of a bicarbonaturria. It's the problem of acid excretion. That is where the problem is. So bicarbonate excretion will be less than 3 in that setting. So which means here there will be no bicarbonaturia whatsoever, which clearly tells that the fractional excretion of bicarbonate will be less than 3, more than 15 in the setting of a proximal RTA. Still you have a doubt. We have one traditional test. That's called a acid loading test. Still, you have a doubt between this alkaline and this alkaline. You have something called an acid loading test, where we load the patient with something called ammonium chloride. This ammonium chloride is going to dissociate into H+. Of course, this is going to give a lot of H+, and this ammonium will be anyway, nevertheless, excreted in the urine after giving ammonium chloride. So once you give a lot of H+, this H+ has to be excreted through the distal nephron only. Because I told you the secretion of H+ and the fixed acids excretion is basically based on the distal nephron's ability. So in proximal artery, distal nephron can excrete H+, wherein distal artery, distal nephron cannot basically excrete H+. So the urine will still remain alkaline because they can't excrete H+. After giving acid load, if the urine becomes acidic, because the distal nephron proximal artery is quite okay, so they can excrete H+, and the urine will become acidic. So after giving an acid loading test, if your urinary pH becomes acidic, then that's a straightforward thing that confirms that this patient is having a distal renal tubular acidosis for sure. And not acidic means the patient is having a proximal renal tubular acidosis, and if it remains alkaline, the patient is having definitely a distal renal tubular acidosis for sure, and cannot be a proximal renal tubular acidosis in this setting. And currently we don't use this acid loading test anymore. It's outdated completely because it causes severe hemolysis and associated kidney injury in the first place. So that's only for a confirmation, gold standard in the olden days. Currently we don't use any sort of test like that. We have a lot of alternatives to find out whether it's a proximal or a distal renal tubular acidosis. As far as the causes, etiology of distal artery is concerned, we have some selected etiologies here. So remember, there are two kinds. Anything that raises the urinary calcium, anything that produces high urinary calcium is a problem. I mean, that itself can damage the distal tubule. You remember, distal artery can produce hypercalciuria, but anything that produces hypercalciuria can also produce distal artery. So it's like a vice versa kind of a scenario. So what are things that produces high serum calcium? So if there is high serum calcium, there will be increased urinary calcium. What are the situations that produce this kind of a scenario? So typically, this happens in the setting of hyperparathyroidism. Number one, I can write HPT. I can write HPT alone. Hyperparathyroidism, especially primary hyperparathyroidism, can produce this kind of scenario. Then multiple myeloma can produce this kind of a scenario. Remember, that is the thing about multiple myeloma. Remember, multiple myeloma can produce both distal RTA because of hypercalcemia, as well as proximal RTA, because multiple myeloma can result in development of amyloidosis as well. So you have to be little clear in that. And apart from that, you can develop to some extent in sarcoidosis, because sarcoidosis is also one condition which produces hypercalcemia and hypercalciuria. So you can vaguely remember sarcoidosis also in this setting. Apart from that, you have a variety of drugs that can result in development of distal renal tubular acidosis. And the most important drug, as far as I know, for exams, is the amphotericin B, which is a typical drug that produces distal RTA, because amphotericin B is extremely toxic to the distal nephron. Like calcium, how it is toxic to the distal nephron, amphotericin B is extremely toxic to the distal nephron. Amphotericin B works by introducing pores in the fungal membrane depending on the pH, especially if it is acidic. Since the acidic pH is typically seen in the distal part of the nephron, so they can also induce pores in the distal nephron by arranging themselves in form of a tubular structure, so that the distal nephron will be damaged, and you can result in distal RTA kind of a picture. So amphotericin B is very important. Then you have other drugs that damage the distal nephron, like lithium, demiclocycline. Previously, we have been using this as a treatment for patients who are suffering from SAADH once upon a time. But even though you would have studied in your pharmacology that lithium and demiclocycline can induce diabetes insipidus, especially nephrogenic diabetes insipidus. Why? Because they damage the distal part of the nephron. So same thing, because they damage the distal part of the nephron, because, not only because the property to induce a diabetes insipidus, they can also produce a distal RTA-like kind of a picture. So these are the three important drugs that we need to know. Apart from that, we have a lot of other drugs. One more condition that is associated with increased urinary calcium is something called as a medullary sponge kidney. These are rare causes, but still worth knowing. Medullary sponge kidney, one of the important conditions that increase the urinary calcium. If you take medullary sponge kidney and study in nephrology, one of the main problems in medullary sponge kidney is their recurrent renal stones. That is because of increased urinary calcium ability. So remember, you can now tell urinary calcium, if it's increasing, can cause distal RTA, and distal RTA, if it's happening, then itself can cause an increased urinary calcium. This is either way around, vice versa. And there are a lot of autoimmune conditions. So in exam, whenever you see an autoimmune condition, a connective tissue disorder, autoimmune condition or a connective tissue disorder, this will result in the development of a distal RTA. Like for example, SLE, Sjogren. I think yesterday I told in great depth and detail about Sjogren. So I think day before yesterday I feel. So Sjogren, I told you multiple times in exam, it's very important. That the only question that is important in Sjogren is its ability to cause distal RTA. 1,000 times asked question in exam. So Sjogren, rheumatoid arthritis can cause this. So many connective tissue disorders can cause, or some vascular disorders can cause this. For example, sickle cell disease can produce. Then obstructive uropathy can produce. Then renal transplant. Renal transplant, because the immune damage is not going to be limited only to the proximal tubule. It can be coming in the distal nephron also. Saurabh is asking SRC. SRC is a completely different picture. SRC is basically a fibrinoid necrosis, or we can call it as like a, that onion skin hyperarteriosclerosis that is happening at the glomerular vessels. So hypoperfusion, ischemia to the glomerulus. That is the reason for development of SRC, not your, this kind of tubular damage. The problem there is completely glomerular issue. So this should not be confused there. SRC produces high creatinine, whereas the causes we have seen here does not produce high creatinine. So, in the sense, like at least vaguely, they can produce, but if there is high creatinine, you will not be able to diagnose an RTA. It's very difficult to diagnose renal tubular acidosis, because how will you tell it's a NAGMA if the patient is having already renal failure? It's very difficult. High calcium leading to high urinary chloride for ionic balance. No, I don't think so. And that is not the case. It's vice versa is true, but there is no theory or hypothesis to tell that high serum calcium is leading to high urinary chloride. I don't think so. To maintain the balance, there's nothing like that. So the balance between ions is completely different. Okay. So even though this table looks messy now, I'll finalize what I want to tell right now. But even though this table looks messy now, you know what are the problems. These 4 are the primary problems. That normal BP, normal creatinine, hypokalemia, and normal gap metabolic acidosis. And of course, what are the other problems and what are the etiologies that are happening in different kinds of proximal versus distal RTA. Then we still have not discussed about this type 4 RTA, that is a hyperkalemic RTA. So how will you tell what is the problem in this type 4 RTA, that is hyperkalemic RTA? Remember, hyperkalemic RTA typically is called type 4 RTA, and it is due to either hypoaldosteronism or defective aldosterone action, reduced aldosterone action. Either the aldosterone level itself is low, or hypoaldosteronism, or there is a reduced aldosterone action. So any one of them will result in a development of a type 4 RTA, that is hyperkalemic RTA. So you know that aldosterone is important for sodium reabsorption, potassium excretion, as well as H+ excretion. That's why I'm telling multiple times, whenever you don't have aldosterone, you will not be able to absorb sufficient amount of sodium, sufficient amount of potassium will not be excreted, and sufficient amount of H+ will not be excreted. So it could be a tubular issue. In fact, a tubular issue. That's why resulting in a normal and gap metabolic acidosis, because the defective H+ will result in H+ accumulation here. Because H+ accumulation is happening, it will result in a normal and gap metabolic acidosis. Usually it will be extremely mild, even compared to that of the proximal renal tubular acidosis, and they'll be having hyperkalemia, because in this setting the potassium also will not be able to get excreted. So this is a problem that is happening in the setting of a type 4 RTA. So you will result in hyperkalemia and your normal and gap metabolic acidosis. Clear? So what are the conditions? What are the conditions that can produce low aldosterone or low aldosterone action? So for that, I can divide into conditions that produce low renin or conditions that have high renin. So we can put low renin hyperkalemia or a high renin hyperkalemia. So conditions that have low renin means I'm having some problem in the kidneys. So that is why I'm having a low renin. So I'm not able to produce renin from the kidneys. So now you need to know about where the renin is getting secreted in the kidneys. So for that matters, if you take the tubules in a quick way, if you want to understand. So let us take the glomerulus here. This is the afferent and the efferent arteriole. And renin is basically secreted from the juxtaglomerular apparatus. You know, renin means it's coming from the juxtaglomerular apparatus. These juxtaglomerular apparatus are nothing but a specialized area in the afferent arteriole. So this is afferent for that matters. Let us assume this is an efferent arteriole. In the afferent arteriole, you have some specialized endothelial cells that have differentiated into a different way. And these are called as juxtaglomerular cells, juxtaglomerular apparatus. And from this only, they are going to secrete renin. So how they secrete renin? They sense the perfusion. So whenever the perfusion is low, they will secrete renin. And this renin secretion will stimulate the liver to produce. Sorry, liver I have drawn a worst way. So let us assume this is the liver. So in the liver, you will result in secretion of angiotensinogen. This angiotensinogen is going to produce will be converted to something called angiotensin 1 spontaneously, and this angiotensin 1 in the lungs, AT1 in the lungs, with the help of angiotensin converting enzyme will result in formation of angiotensin 2. This angiotensin 2 is the one that is going to produce aldosterone, and this happens in the adrenal gland in the zona glomerulosa of the adrenal gland. They have angiotensin 2 receptors. These angiotensin 2 receptors are the ones that are going to produce, since the angiotensin 2 and produce aldosterone, this aldosterone is the one that is going to act on the tubules, resulting in this sodium reabsorption, potassium excretion, and H+ excretion. So we know that very well. So this is the process that's happening. And there are many stimulus for the production of, like renin from the juxtaglomerular apparatus. One thing is the low perfusion. Low perfusion is one of the main things that produces renin. Stimulus number 1. Stimulus number 2 is beta-1 stimulation. This is a relatively less important stimulus, but still, because this juxtaglomerular apparatus has beta-1 receptors. So beta-1 stimulation, adrenergic stimulation can result in renin stimulation, renin production. And the third stimulus for renin production is that is tubuloglomerular feedback. So what do you mean by tubuloglomerular feedback? You have something called macula densa. So students who don't know what is macula densa, I think you need to go back to physiology again. So macula densa is the specialized tubular structure that is present in the distal convoluted tubule, which basically senses the sodium. Basically senses the sodium that is coming in the tubule. So this sodium that is coming in the tubule, if it is low, if there is low sodium in the tubule, they will produce something called a prostaglandin I2, that is prostacyclin. This prostacyclin from the macula densa, PGI2, is going to act as a stimulus to produce renin. So which means there are 3 stimulus for renin. Low perfusion. Second is beta-1 stimulation by adrenergic activity. Third is low sodium in the filtrate. By producing prostaglandin I2, they stimulate the renin production from the JG cells. So these are the 3 ways where you can reduce the, produce renin. So low renin means there should be some problem here. For example, whenever you have a low renin, it can happen in the setting of diabetic nephropathy. Many students do ask why in diabetic nephropathy you get this kind of low renin kind of a picture. That is because in diabetic nephropathy, the first event that happens is hyperfiltration. Hyperfiltration. That is the first thing that happens in diabetic nephropathy. Again, you might ask me why there is hyperfiltration in diabetic nephropathy. That is because if you take the glomerulus and if you take, this is the afferent and this is the efferent, in diabetic nephropathy, there will be microvascular issue, which means thickening of the base membrane will be there. And the most important area that thickened is efferent arteriole, because efferent arteriole is getting thickened in diabetic nephropathy. You can remember, like, the fluid is finding now very difficult to move out, which means it increases the intraglomerular pressure, that's called as IGP, that will result in more filtration. More filtration means more sodium is going to come. If they sense that the base filtrate sodium is more, if the filtrate sodium is more, the amount of prostaglandin I2 that is secreted will be less, and subsequently there will be a low renin production. So diabetic nephropathy being a hyperfiltration disorder, you might end up with the hyperkalemic RTA, which is very common in the setting of diabetic nephropathy. Similarly, if you are going to give NSAIDs, it's easily understandable. NSAIDs can produce low renin kind of a picture because they block the prostacyclin production, PGI2 production. PGI2 is important for production of renin by tubuloglomerular feedback. So that is one reason why you may be seeing low renin in that setting. NSAIDs can cause low renin and subsequently result in hyperkalemia and metabolic acidosis. And for that matters, beta blockers. Beta blockers can produce, why especially non-selective beta blockers can result in hyperkalemia due to variety of reasons. Beta blockers can produce hyperkalemia. Beta 2 agonists, they are going to produce hypokalemia. But beta blockers, you can remember as an opposite effect, they can result in development of hyperkalemia. And if you block the beta 1 receptor, again, renin production will be a little low in this particular setting. Then there are some problems that can damage this apparatus. The macula densa can be damaged. The juxtaglomerular apparatus can be damaged. So what are the processes that damages macula densa and the juxtaglomerular apparatus, or the communication will be lost? Where you release PGI2, that PGI2 will not reach the JG cells properly, especially if you have some problem in the interstitium. Interstitial nephritis can result in low renin production because the that area, if it gets fibrosed, like you will not have a proper communication with the JG apparatus. So renin production will be reduced. And if there's interstitial fibrosis, even to an extent, your macula densa and juxtaglomerular apparatus will also be affected to a great extent. And apart from that, you can get this kind of problems in calcineurin inhibitors, which also produces sort of interstitial damage and nephritis. Like cyclosporin and tacrolimus can do this. And remember, they are basically nephrotoxic drugs. And even HIV can do a similar picture, which can result in the development of a low renin. Because of that, you will result in low angiotensin. And because of that, you will result in low aldosterone. Because of that, you will result in hyperkalemia and metabolic acidosis. As far as high renin is concerned, so high renin causing hypoaldosteronism may be due to two reasons. One, either it could be a hypoaldosteronism, which means the aldosterone production is low aldosterone production. So number one, result in high renin only, it will not result in low renin. Or probably there could be a resistance to aldosterone. The tubules are not responding to aldosterone. Aldosterone is still there, but tubules are not responding to aldosterone. So remember, in both these conditions, renin may be high or even normal, but here the aldosterone levels will be low. Here the aldosterone levels will be high, because in the other condition, we are talking about a tubular resistance to aldosterone. Here we are talking about a hypoaldosteronism. What is the condition that reduces the aldosterone production? It's very easy to understand here. We know to produce aldosterone, you need adrenal gland. If adrenal gland is not functioning properly, then you can result in hypoaldosteronism. Or if you block the angiotensin converting enzyme, your angiotensin 2 will be reduced. Because of that, your aldosterone production will be reduced. So which means one of the most important components of high renin but low aldosterone related hyperkalemia is ACE inhibitors and angiotensin receptor blockers, which is easily understandable, which can result in development of hyperkalemia and acidosis. And next is your heparin. How heparin produces hyperkalemia and type 4 RTA? Heparin can damage the receptors. That angiotensin 2 receptors are there in the zona glomerulosa. Heparin can damage the angiotensin 2 receptors in the zona glomerulosa. Because of that, you might result in low aldosterone production and subsequent type 4 renal tubular acidosis. And if there is an adrenal insufficiency, especially if it's a primary adrenal insufficiency, you might get this picture. Because in primary adrenal insufficiency, the zona glomerulosa will be lost. Because of that, you will not be able to produce sufficient amount of aldosterone. So these are three important causes that we need to know in this particular setting. So then we have tubular resistance to aldosterone, because there are some medications and there are some conditions which can damage the tubules so that they don't respond to aldosterone properly. Which means the problem is not anywhere. The problem, it's here. In final condition, we're talking about the problem is here. This is the tubular resistance to aldosterone. So what are the conditions that produces tubular resistance to aldosterone? First, drugs. Of course, in the sense, which of the drugs will make the tubules insensitive to aldosterone? Of course, it is mineralocorticoid receptor antagonist. Even if there is aldosterone, in the presence of a spironolactone or eplerenone, the mineralocorticoid receptors will be blocked so that the aldosterone will not respond properly. It's like creating a resistance at the level of tubules. So spironolactone, eplerenone, mineralocorticoid receptor antagonist. Then your epithelial sodium channel blockers. So we know both these are together called as potassium sparing diuretics. ENaC blockers also, even if there is aldosterone, they won't respond. They cannot absorb sodium, so that potassium cannot be excreted. So there will be hyperkalemia and acidosis. At the same time, you can get with trimethoprim, sulfamethoxazole, and you can get with pentamidine also. So if somebody asks you why you get with TMP, SMX and pentamidine, because they are structurally similar to triamtrin. You know what is triamtrin? Triamtrin is a ENaC blocker, potassium sparing diuretic again. Because these drugs are structurally similar to triamtrin, they can work like triamtrin in the tubule, and they can produce a sort of aldosterone resistance and result in hyperkalemia and metabolic acidosis. Then you can get in autoimmune disorders like SLE, where they can damage the tubules. You can get with diabetes mellitus, which can again damage the tubules. Then again interstitial nephritis will come here. But more than interstitial nephritis, it's the tubulo-interstitial disease. Pure interstitial disorder will not cause any problem of aldosterone resistance, but tubulo-interstitial disease. If a disease is affecting tubules and interstitium both together, so then you can result in the development of this kind of aldosterone resistance. Then vascular causes like sickle cell disease can also result in development of aldosterone resistance. And even calcineurin inhibitors here also they can produce, because calcineurin inhibitors, they don't really cause interstitial damage. because we know that to absorb this sodium and to excrete potassium, we need this basolateral sodium potassium ATPase. Calcium inhibitors are known to damage the basolateral sodium potassium ATPase as a side effect. Because of that also, calcium inhibitors can result in development of tubular resistance to aldosterone as well. So calcium inhibitors, one of the important side effects is hyperkalemia. You would have studied many times in your pharmacology. They can produce hyperkalemia by different mechanisms that is involved. So these are the conditions that can produce hyperkalemia and the acidosis, that is normal-gap metabolic acidosis. One is low renin causing low aldosterone. Second is high renin but still low aldosterone, whereas problem is in the adrenal gland. And next is aldosterone resistance, that is tubular resistance to aldosterone. We have so many drugs and so many causes that can produce this kind of a picture. And tubular resistance to aldosterone can be caused by another thing called pyelonephritis. Even this can produce tubular resistance to aldosterone. Pyelonephritis, even obstructive uropathy. So many conditions are there which can produce tubular resistance to aldosterone. So don't worry about that. Clear? So now you know the causes of different kinds of RTA. You have a proximal RTA, you have a distal RTA, and you have a type 4, that is hyperkalemic renal tubular acidosis. As far as RTA is concerned, you know the common things. There should be NAGMA. That's the most important thing. So non-man-gap metabolic acidosis. That's a very important rule to diagnose RTA. That is the reason why whenever there is a renal failure, creatinine is high. So if the patient is having HAGMA, then it becomes really difficult to diagnose a renal tubular acidosis. That's why I always tell most of the times, if it's a normal creatinine, then it's easy to find out a renal tubular acidosis. Or if it's a normal BP, then it's easy to find out a renal tubular acidosis. Suppose the creatinine is high, renal failure is already there, then it confuses the picture and it's very difficult to diagnose an RTA in this setting. Usually in exam, this is the situation where you diagnose a renal tubular acidosis. Okay, now we know so many things. We have understood a lot of things about renal tubular acidosis, which is a very important topic for exam. Finally, let us try to consolidate everything. So let us see the type of RTA. Okay, type of RTA and what will be the finding. So I'm going to put a proximal type 2 RTA first, then a distal type 1 RTA next, and finally a hyperkalemic type 4 RTA at the last. And what will be the findings? So first of all, what is the type that we call? It's type 2, it's type 1, it's type 4. Clear? So what is the primary problem here? Primary issue here. The primary issue here is bicarbonate reclamation. That is what is the problem here. The primary issue in distal RTA is H+ secretion. That is where the problem. That's not happening properly. In type 4 RTA, the primary problem is aldosterone. Either it is not getting secreted properly, or if it is not, it's not acting properly. So aldosterone is the main issue here in type 4 RTA. Either aldosterone production or aldosterone action. Something is having a problem. That's the primary issue here. So as far as the acidosis is concerned, the mildest form of acidosis you will encounter in type 4 RTA only, I told you. And moderate acidosis here and severe acidosis here. So that can be substantiated by the serum bicarbonate. If you take the serum bicarbonate in type 2, it will be 12 to 20 usually. It will be less than 10, usually around 5, 4 only in the setting of type 1 RTA. And type 4 RTA, it will be in the range of more than 17. Still, it will be less than 24, but more than 17. Very mild acidosis. What is the potassium state? Potassium will be low here, and it will be high, hyperkalemia. Remember the fact that distal RTA is the one that's going to produce a severe hypokalemia compared to that of a proximal RTA. Fine. This is the potassium. And normal and gap metabolic acidosis will be seen in all these three things. So there won't be any problem at all. And as far as the urinary bicarbonate is concerned, urinary bicarbonate will be definitely increased here. In the proximal RTA, it will be no much change in the distal and the type 4 RTA. Then you have fractional excretion of bicarbonate. To substantiate that, we know it will be more than 15 in proximal RTA. Bicarbonate is a very important finding. It will be less than 3. It's not a feature of other two types of RTA. As far as the urinary pH is concerned, definitely we know it will be alkaline in the setting of distal RTA. There is no doubt about that. But in the presence of acidosis, urinary pH will be acidic. If the distal's acidification capacity is intact, so urinary pH must be acidic only, which means by definition it will be less than 5.3 in both these conditions. But here it will be more than 5.3. In fact, it will be 6, 7 usually, very alkaline urine. That's what you will encounter here. On the other hand, finally, if you take the urinary anion gap, because all these are normal anion gap metabolic acidosis, everywhere you are having NAGMA. So it's important to tell what will be the urinary anion gap as well. So if you give urinary anion gap, if you see the urinary anion gap will be definitely positive in the setting of, it will be elevated, positive in the setting of a distal RTA, we know that. And once again, because it's a renal cause, it will be positive here because aldosterone deficiency, I told you in Addison, for example, I told you. So aldosterone deficiency, again, it will produce a positive urinary anion gap only, but here it is relatively variable. It can be positive or negative. The same thing we have discussed already. As far as the other issue, other diagnostic issue, as far as exams are concerned, the most important diagnostic point as far as proximal RTA is concerned is osteomalacia. Whenever they give bone problems, you think about proximal RTA, they might be having associated Fanconi syndrome. That will be the diagnostic point in exam. As far as the distal RTA is concerned, the nephrocalcinosis will be the diagnostic point and the low urinary citrate will be the diagnostic point. So if they give any of these words, low urinary citrate or nephrocalcinosis, it usually goes towards a distal renal tubular acidosis. And finally, the most important diagnostic point, there's no much diagnostic point. Here, usually the hyperkalemia itself is the most important diagnostic because other two will have hypokalemia only and not hyperkalemia. So if you want to really differentiate between the different causes of renal tubular acidosis, and this is the case, and this is how you're going to differentiate between different causes of renal tubular acidosis. That's all. Most important. If you consolidate this table finally, and if you're able to understand each and every point in this table, then it's more than enough. And usually what they will ask you is, what is the initial treatment? For example, if the patient is having a proximal RTA and distal RTA, in both these settings, treatment of underlying cause is definitely important. I'm not telling no. The patient is having 1004 induced proximal RTA, stop 1004. The patient is having multiple myeloma, treat the multiple myeloma. But more than that, the initial acidosis you will treat with bicarbonate. Initial acidosis, you're going to treat with bicarbonate. You're going to give treatment in the form of bicarbonate. That's how you're going to treat the initial acidosis. If you want to treat bicarbonate with bicarbonate therapy, how much bicarbonate you will be needing? Remember, as far as type 1 RTA, proximal RTA is concerned, there are so much of bicarbonate loss happening. How much ever bicarbonate you give, usually it will not be able to, it's like a leaking tank. It will be keeping on going. So if you give bicarbonate, if they ask the dose will be extremely high. The dose needed is high. Typically, they will be needing more than 5 millimoles per kilogram per day. Typically, they need a high dose of bicarbonate because of the severe bicarbonaturia. And one important complication that you will see with this bicarbonaturia is the more and more bicarbonate you give, the urine pH might change. One thing, that's not a complication, urine pH might become more alkaline because more and more bicarbonate will start getting lost in the urine. And second important complication is as more bicarbonate starts moving into the urine, they'll make the apical membrane more negative, that will suck more potassium out. So they might worsen the hypokalemia. So usually hypokalemia will not be very severe in proximal RTA, but after giving bicarbonate, the hypokalemia might become worse because they drag the potassium out, this bicarbonate. As far as distal RTA is concerned, the dose required is quite less. Typically in the range of 1 to 3 millimoles per kilogram. That is how you diagnose it. That's that much only you need for a distal RTA. But one important thing is the bicarbonate itself will try to improve hypokalemia because once the acidosis is improved, that itself will improve hypokalemia. Remember, after giving bicarbonate, if it worsens hypokalemia, it's proximal RTA. If it improves hypokalemia, that is a distal renal tubular acidosis. That's again very important. The dose required is more for proximal, less for distal. And as far as the type 4 RTA is concerned, you will be asked with something called a fludrocortisone test, even though it is not needed. Fludrocortisone test. After fludrocortisone test, if your hypokalemia improves, in the sense we usually see something called TTKG. The TTKG improves after giving fludrocortisone, or TTKG remains the same. TTKG means transtubular potassium gradient, which we'll be discussing in hypo and hyperkalemia chapter. But nevertheless, if TTKG improves with fludrocortisone test, we know it is basically mineralocorticoid deficiency. So mineralocorticoid here we mean is aldosterone deficiency, because fludrocortisone being a equivalent agent of aldosterone. Here we mean it's aldosterone deficiency. And if TTKG remains the same, which means if it is still less than 7, it does not improve at all, even after giving fludrocortisone, which means here there is aldosterone resistance. Aldosterone resistance. If you still want to further differentiate aldosterone deficiency, see the renin. If the renin is low or the renin is high. If the renin is low, you know it's a low renin cause. If the renin is high, it's a high renin cause of hyperaldosteronism. We know what is a high renin cause. That is in the adrenal gland. Typically, the problem will be in the adrenal gland, or probably ACE inhibitor, or ARBs, or probably your heparin can cause this kind of a picture. Low renin means, you know, beta blockers, NSAIDs, diabetic nephropathy. So many things can cause this picture. We have discussed already. So they will ask you about the evaluation also. But the best treatment in type 4 RTA is, again, treating the underlying cause, or probably you can give a fludrocortisone, because fludrocortisone might respond. Sometimes if it's a deficiency, then definitely fludrocortisone will improve the hyperkalemia and the acidotic state. But the main thing in all the types of RTA is because, main thing in all the types of renal tubular acidosis, treatment of the underlying cause. That itself will resolve so many issues. And these are the typical table that you need to know with regards to the renal tubular acidosis. Even though it's a complicated topic, I think renal tubular acidosis would have made some sort of sense to you. So shall we move on to the next topic? Next sense, we are going to move on to the metabolic alkalosis section. Do you understand? I think everyone should be able to get a grasp, isn't it? This is a very easy topic, but quite complicated. Easy and complicated are little different. Complicated means you need to know a lot of things to understand this. But it's once you know all these things, it must be quite easy only. It will never be tough. It's a very easy topic. Shall we move on? Yes. The next one, what we are going to talk is on the metabolic alkalosis. Metabolic alkalosis. As far as metabolic alkalosis is concerned, we are going to basically divide into two. So one is a chloride resistant metabolic alkalosis and a chloride responsive metabolic alkalosis. Chloride resistant metabolic alkalosis or chloride responsive metabolic alkalosis. This is how we basically divide. Anish is asking Lidl's, Barter's, Alport, Gordon's. Just have some conscience, man. How can I explain everything in one particular? We are talking about acid-based disorders now, and you want to tell Lidl's, Barter's, Alport, Gordon, everything in the same chapter itself. Then what about the other discussions? We have other discussions, isn't it? You need to wait. The patience is the key here. So we have chloride resistant metabolic alkalosis. Then you have chloride responsive metabolic alkalosis also. So in that setting, we can this also call the, because chloride means we are talking about the normal saline, so we can call it as a saline resistant metabolic alkalosis, and we can also something called as saline responsive metabolic alkalosis. And actually speaking, the current students, what to tell? The eager to learn is so much, and I appreciate that a lot. But I think if I have had even 1% of the eagerness that what you have right now, I'd have gone somewhere, I think. Because during my days when I was a pre-final or final, we don't really read for any purpose. I go home and I just sit, I will read. Just because I don't want to lose that touch. 2 hours, that's mandatory for me. I'll read 2 hours a day. And then I'll enjoy, I'll go out, come back, go to wards, meet my friends in hostel, then again come back. So this is what my usual routine is. Now, if you take a student who's coming from the first year, second year itself, you see their eyes, they'll be they wanted to know all the stuff in the world in a single day. They need, which means when I learn. This is a sort of, I don't know whether this is something to be proud of or something dangerous or something to be scared of. I don't know. But I really don't know where this kind of scenario has started. And students are nowadays, like, which means what they're trying to tell is whenever I take a live class, they ask like, I want everything. In the sense, like, the first thing I go to a face-to-face session or anywhere, they tell like, sorry, tell everything. Whatever is possible, you tell. No problem. The more notes you give, the more better you are. The more points you tell, the more better you are. That's how they assess a particular teacher. But I couldn't believe, like, where this transition has happened, because my generation, when we saw, for us, reading is just a passion. Now, in this particular generation, reading has become something like, or not reading, they don't read, of course, sorry for the trouble. I don't think they read, but they want information. So there is a difference between trying themselves and reading and wanting information from someone. So they want information. And I think maybe in the next 10, 20 years, there will be a software which can directly infuse information into your brain directly. There might be some kind of a software also, but I don't really know whether that will be happening or not. But nevertheless, I appreciate really the knowledge thirst of the students, where they wanted to learn everything in 1-2 days. And even if they wanted in 3 seconds, if you are able to tell everything also, they'll be very happy. But that knowledge thirst is something to be appreciable, of course, because we never had that kind of knowledge thirst. If there was no need, okay, even I had a need during that time. It's not like I didn't have a need at all. Ankit is telling if there was no need. Even I had a need. I had a, like, kind of a scenario, like, what is that? That need kind of scenario, all India kind of a scenario during our time. I think in 2009, 10, still there were around 1 lakh to 1,10,000 students. But this is something very different what we are seeing right now. The amount of that kind of knowledge thirst that students are having. Competition was different. Yeah, of course, competition was a little different. But again, like, everything is relative. If you tell like in 1980s, people were not struggling at all. Again, you cannot compare 1980s with 2020s. If you think that now current economy is good and the people are not suffering, relatively speaking, now the people are suffering in a different way. In 1980s, people were suffering in a different way. So everything you take in a very relativistic chance. It's not like absolute. If you tell competition was different, during our time, there are only 1,800 seats in the entire country. Right now, you have 5,000, 6,000 seats. Good seats, in fact, clinical seats, 6,000. DNB has integrated together. Many good DNB institutions have come. So if you tell competition is worsening, then what about the increase in the number of seats? That's also there, isn't it? So, which means it's all relativistic. It's not like you're going to take in absolute terms. To be honest, during my time, there is no AIIMS Bhopal, there is no AIIMS, all this stuff. Ruthlessly, I will be kicked out of the counseling hall. I got a rank of 32 for that matters in one of the AIIMS. 17th rank, medicine got over. And I think 22nd or 17th, I don't know, my friend took 17th rank, medicine got over. 32nd, I was just seeing other people are taking the seats and I just came out, walked out. I didn't get anything what I want. Now at least I have a chance of getting a AIIMS Bhopal or AIIMS, maybe Ranchi is there. So many other options are there. So which means as the competition is increasing, you are having a tremendous increase in the number of seats as well. So for that matters, I would suggest that it's all relativistic compared to that area. Kritika is asking, what are your opinion about INI CET exam? I feel in the current scenario, it's good. At least you will be not going for 4 different exams. One exam, maybe your number of seats psychologically is high and your psychological burden is low because you not write 4 different exams. You want to write just one exam. So if you are writing 4 exams, then your psychological barrier will be very low. And one exam, psychological barrier is high. Even if in this kind of an exam, even if you score a rank of 90, then you have a very good chance of breaking into some good institute. If on the other hand, if you get a rank of 90 in a NIMANS exam, I don't think that's worth at all. Or if you get a 90 in JIPMER exam, and again, if your scenario is worse, I don't think that's a good rank. But in the INI CET, if you get a 90th rank, maybe your chances of getting a good seat is extremely high because one institute or other, anyway, you're going to get a seat. So I believe that, I don't know why students are continuously asking that it is tough, I don't know. What is the point in, see the positive points. One exam, psychological burden very less. Go one time. No need to travel 4 times. No need to waste 4 different days. And at the same time, even if you get an okayish rank, still there is a lot of chance that you might end up with a good seat. So it's good, isn't it? It's really good. I feel it's, if I am the one, I would have welcomed this. I don't know how many of you are hating the INECET. I am actually welcoming it. If I am my personal point of view, if I am the candidate, I am sitting, I'll be actually liking it very much, because my chance of getting seat in the institute is actually high, quite high. Okay. But one negative side, maybe drawback, is that the fact that they might be having a little bit of higher competition, because previously many institute exams, many people drop out. They don't write as like that of the NEET because it's a single exam. Who knows? People might give, because previously there were a different set of students aspiring for AIIMS, different set of students aspiring for JIPMER. Some students were been preparing for PGI. Some students have been preparing for NIMHANS, but now all these will come to the same pool. So maybe a negative side is that competition will be a little high, because many students will be attending that like a NEET exam. But I see the positive side always, because when you keep seeing the negative sides, it always brings you down, and you will be in the dark. You will never improve. So see always the positive sides, bright side. Don't worry about anything. I mean, in this uncertain world, when we don't know that tomorrow we will be alive or not, then what is the point in thinking about all these things? And of course, change is the only thing that never changes. That's a beautiful sentence that I ever know. So change is something which you have to embrace, and anything that does not embrace the change is destined to get extinct. So this is also a proverb that is there. If you can't embrace the change, you will go extinct. Or if you are going to keep brooding about the change that is happening right now, you are definitely like destined to get extinct, and you will not be in the competition. So that's what they're trying to tell. So even anything that the evolution challenges, you take from evolution from the Jurassic time, or maybe even before that, a change is something that is happening quite regularly in the Mother Earth also. And any organism that embraces the change and adapts to the change is the one that continuously survives in this world and goes for the progeny and the species. Anything that has not embraced the change have died. So we can't really tell that I don't want change. I want only the old thing. So changes are meant to be there, and changes will happen in the future also. And embrace it and be happy and take the positive side and keep preparing. Okay. So as far as the metabolic alkalosis is concerned, we have this chloride resistant form of metabolic alkalosis, and we have a chloride responsive form of a metabolic alkalosis. Just 1 second. Chloride responsive metabolic alkalosis. So first, let us talk about the chloride responsive metabolic alkalosis. Here, the main reason is chloride depletion. Chloride depletion is the main reason for development of this kind of alkalosis. So which means what I'm trying to tell is the fact that these patients are having alkalosis because of chloride depletion, which means we know that there is one important entity here, that is this chloride bicarbonate exchanger that is present in the distal part of the nephron. Distal part of the nephron. So if there is no chloride, persistently low urinary chloride, if there is no chloride at all in the body, they cannot eliminate bicarbonate, because elimination of bicarbonate is a part of your natural phenomenon, day-to-day physiology. So slowly over a period of time, the bicarbonate will start accumulating, and you will start resulting in development of metabolic alkalosis. And this kind of chloride responsive or this kind of low chloride related alkalosis will respond to infusion of saline very drastically. The moment you give chloride to this patient and improve the urinary chloride, immediately they are going to get better and their alkalosis will resolve. That's why it's called a saline responsive metabolic alkalosis or a chloride responsive metabolic alkalosis. Even though there is a lot of phases, the initiation phase, maintenance phase, so many things are there, we do not really know about that. Only the causes are going to be the most important. And in that perspective, let me start with one important entity, that diarrhea. What happens in the setting of diarrhea? In the setting of vomiting. So vomiting is a very typical example for a chloride responsive alkalosis. In the setting of vomiting, what you are having is you're going to lose H+ and chloride. There is a hydrogen and chloride loss is there. Because of hydrogen and chloride loss, your chloride will be depleted. There's low chloride. Because of the low chloride, there will be low urinary chloride. Because of the low urinary chloride, there will be alkalosis. Number one. Second point, you can understand that this H plus loss, because this H plus is also lost in these patients, and that can also contribute to the alkalosis to a great extent. So there are two reasons why you get alkalosis and vomiting. I told you, especially in chronic vomiting, this is what will happen. So later on, this situation might resolve. You would have studied something called paradoxical aciduria and all. So this alkalosis is the initial thing that happens. So any, kidney should respond to the alkalosis in a different way. For example, the body is having low H plus, that is alkalosis, which means they should try to conserve H plus, which means the amount of H plus they should lose is actually less. So that's what should happen. H plus secretion should be less so that your H plus retention should be more, because that is to counteract this alkalosis that has been created in this situation. And that's what happens in the initial scenario. But later on, what happens is, because of vomiting induced volume contraction, sodium loss will be now taking over, and they will produce significant volume contraction. Because of significant volume contraction, which happens in the late stages of chronic vomiting, they can result in activation of renin-angiotensin-aldosterone system. Because of activation of renin-angiotensin-aldosterone system, your aldosterone level will be high. Because of the secondary hyperaldosteronism, they try to replace the sodium loss by absorbing more sodium. And on the other hand, as a side effect, they are going to excrete more potassium and more H plus. So vomiting can result in increased urinary potassium loss. At the same time, vomiting can result in increased urinary hydrogen loss as well, which happens in late and chronic stages of vomiting. So many students do ask me, sir, hypokalemia and vomiting, is it a renal cause or is it a GAT cause? When you call vomiting and if you tell hypokalemia, it's always a renal cause of hypokalemia only. Because in vomiting, the hypokalemia is due to renal wasting of potassium due to renin-angiotensin-aldosterone system. But for diarrhea, if you ask, in hypokalemia and diarrhea is due to GAT loss. That's straightforward, because colon has the highest capacity of reabsorbing potassium in the entire intestine. So in diarrhea, it's a GI loss. But in vomiting, it's a urinary loss of potassium. That's the most important point to note. And this is something violating the basic rule. The patient is basically having an alkalosis. Usually you have to actually conserve H plus, but this patient is actually losing more H plus. And this is what we refer to as a paradoxical aciduria. And this paradoxical aciduria will worsen the alkalosis. And for all these things, the basic problem is this vomiting. That is low chloride. This is the basic problem for all these things. So, and the low sodium, that's the basic problem. So that is the reason why NaCl is considered to be the best replacement solution as far as vomiting is concerned. For diarrhea, we prefer RL. Even though on paper it's RL, even for diarrhea, you can give sodium chloride, no problem. But NaCl is considered to be sodium chloride. Normal saline is considered to be the best replacement solution as far as chronic vomiting is concerned, because it contains chloride that can abolish all these kinds of alkalosis. It contains sodium also. It can cause this kind of, sodium also, sodium loss that can be counteracted, so that RAS related worsening of alkalosis will not be there. So that's why NaCl is the best solution for vomiting in the first place. And if you want to prevent the further loss, you have to control the vomiting, or you can give a PPI, proton pump inhibitor, can be given that can suppress the acid production so that you can result in more control of this alkalosis. So PPI is also may be helpful in this scenario. So as far as chronic vomiting is concerned, if you want to control alkalosis, most important is sodium chloride. That is normal saline. Maybe you can add on a proton pump inhibitor or a H2 blocker to control the acid production so that alkalosis will be resolved. But the main idea is to control the vomiting. That's the most important there. So that's why these kind of causes we'll be calling it as a chloride responsive alkalosis. So the first cause in chloride responsive alkalosis is GI loss, that is vomiting. Number one. Number two, equivalent to vomiting. What are the conditions that are equivalent to vomiting? You have nasogastric tube suctioning. There are some patients with intestinal obstruction where you need to continuously suck the nasogastric tube. So in that setting, you might result in a chronic vomiting kind of a scenario. So you can result in alkalosis. And other GI causes include villus adenoma. You know very well villus adenoma can produce alkalosis. Then there is something called chloridoria, which is something which is not important for us right now. And other causes is something called post-hypercapnia. post-hypercapnia metabolic alkalosis there. Remember, this is something easily understandable. Usually if there is a chronic hypocapnia, what do you mean by chronic hypocapnia? Chronic decrease in the CO2 levels in the body. Or you have a chronic hypercapnia, which means what is that? Chronic increase in the CO2 or a long-standing increase in the CO2. So what happens in this scenario? If there is a chronic hypocapnia, let us assume suddenly you may make this carbon dioxide normal. Suddenly you have normalized carbon dioxide because you have controlled the hypocapnia now. And this hypocapnia would have induced one compensated response. What is that compensated response? That is decline in the bicarbonate. This is nothing but acidosis. So they might have a metabolic acidosis. But this is a compensated response, which is not called by a different name. That's a compensated response there. Now, because metabolic events take some time to recover, now you have suddenly normalized the CO2. This bicarbonate would have taken time, which means the bicarbonate will still maybe in the lower range despite this normalization of CO2. So you might be seeing a picture where CO2 is normal, bicarbonate is only low, so you can induce a sort of a metabolic acidosis. That's why in textbook, especially if you take Harrison and C, they would have given post-hypocapnia acidosis. What do you mean by that? Post-hypocapnia acidosis. That is because this bicarbonate's inability to become normal immediately, which means it will take some time, 2-3 days. Till that time, the bicarbonate will be low. It will not recover. But the carbon dioxide can be recovered suddenly because it's a respiratory problem. In patient ventilator, you can immediately recover it. So that's why probably that's something called as a post-hypocapnia metabolic acidosis. Similarly, post-hypercapnia, same thing. The patient is having high CO2 for some time. Suddenly, due to your ventilator intervention or due to some reason, you have normalized the CO2. Here, the ABG will show normal CO2. But now, because as a compensated response, the patients have developed a high bicarbonate. Because now you have normalized the CO2, but the bicarbonate will not change immediately. It will take some time because kidneys will take some time to normalize it. So it will result in a situation of a metabolic alkalosis. This is what we refer to as a post-hypercapnia metabolic alkalosis. So do you understand what you mean by post-hypocapnia metabolic acidosis and post-hypercapnia metabolic alkalosis? If you study Harrison, each and every single word can be explained in Harrison. Everything has a reason and everything has an explanation. It's not, I mean, don't just try to mug it up the cause. You can have the, especially if you're a final year or a pre-final year, if you are going to read Harrison, try to read Harrison with understanding. Then only you will be able to understand. Otherwise, you will not. I don't know. As I told you before, one pre-final year student told me he read Harrison 3 times. I don't think if you enjoy and read Harrison, if you want to know everything in Harrison, it will take at least 10 years to read complete Harrison. It's not that easy. Each and every word has a meaning there. Post-hypercapnia can result in metabolic alkalosis in that setting, or cystic fibrosis. Why in cystic fibrosis? Because in cystic fibrosis there will be increased sweat chloride. Again, it's a kind of a chloride loss only. That's why you get metabolic alkalosis here. Then you can result in alkalosis because of long-standing loop and thiazide diuretic use, because loop and thiazide diuretic use can result in severe chloride and sodium depletion in the body. So long-standing loop and thiazide diuretic use may result in the development of course, metabolic alkalosis. We know that. That's because of chloride depletion, and they can result in hypokalemia as well. Chloride resistant. So as far as chloride resistant metabolic alkalosis is concerned, usually this will be due to high aldosterone, because here the chloride is not the problem at all. So if chloride is not the problem, still you are getting alkalosis, means there should be some other mechanism. That some other mechanism is aldosterone. If there is some reason where the aldosterone is working too much, so this will result in more sodium, more H+, and more K+. We know that. So this is like the typical mechanism of high aldosterone. Whenever aldosterone is high or the action of aldosterone is high, you're going to result in this kind of a picture. You will result in alkalosis. Here, there is nothing for chloride to play. There is no role for chloride to play. So that's why even if you give a saline, here the patient will not improve, or there is no need to give saline here. That's what we call as a chloride resistant or a saline resistant metabolic alkalosis. Now you can divide into 2 kinds. One is hypertensive chloride resistant and normotensive chloride resistant metabolic alkalosis. As far as hypertensive chloride resistant metabolic alkalosis is concerned, it's always due to either high aldosterone or it's a increased aldosterone action, either of them. So high aldosterone can be primary or secondary, we know that. So it can be primary hyperaldosteronism, where the main problem will be in the adrenal gland. It could be a tumor in the adrenal gland, or it could be adrenal hyperplasia. Something is producing high aldosterone. That's primary. Or it can be a secondary hyperaldosteronism. Secondary hyperaldosteronism causing hypertension means usually you will encounter in a renovascular hypertension. Classic cause. Renal artery stenosis, fibromuscular dysplasia, low renal perfusion because of that high renin, high aldosterone causing this condition. Increased aldosterone action. Or I can tell aldosterone-like action you can have. So this is a non-aldosterone mineralocorticoid excess. This is what referred to as a non-aldosterone mineralocorticoid excess. This is another name for increased aldosterone-like action. So where there are many conditions are there. For example, there is something called a Liddle syndrome. There is something called a licorice ingestion, 11-beta-HSD deficiency. So many things are there in this. So these are non-aldosterone mineralocorticoid excess, which means it could be exogenous mineralocorticoids also, like taking too much of fludrocortisone. They work like aldosterone, but there is no excess of aldosterone, which means aldosterone-like action that is increased in this scenario. There is three kinds of scenario here. So Liddle's, licorice, exogenous mineralocorticoids will come in this setting. In this, as our friend asked previously, what do you mean by Liddle syndrome? Liddle syndrome is a very simple syndrome. It's an autosomal dominant disorder where you have this epithelial sodium channels, and these channels will have a gain of function mutation. Because the gain of function mutation, even without aldosterone, they're going to take up more sodium. I told you taking up more sodium will be reflexly associated with increased potassium excretion and H+ excretion. Here, there is aldosterone has nothing to play here. Even without aldosterone, they are taking up more sodium because of gain of function mutation of ENaC channels. And of course, you're going to result in more urinary potassium and more urinary H+. This will result in hypokalemia and metabolic alkalosis. And of course, this increased sodium reabsorption will result in hypertension. So actually, this will mimic a hyperaldosteronism picture, but there is no excess aldosterone. Actually, patient is having in fact, a suppressed aldosterone because here the aldosterone is innocent. It's not producing any problem. That is why this is also referred to as a pseudo-hyperaldosteronism. Remember, Liddle syndrome is an autosomal dominant mutation, dominant defect, and it's hyperactivation of ENaC channels due to autosomal dominant inheritance or mutation of the ENaC channels. So the treatment of choice will be breaking these ENaC channels by giving probably a ENaC blocker like amlodipine triamcinolone. So this is going to be the treatment for Liddle syndrome. So similarly, you have a lot of other things like licorice ingestion, which can mimic a similar scenario. Or if you are giving exogenous mineralocorticoids, here the endogenous aldosterone will be suppressed because you're taking exogenous mineralocorticoids that is stimulating the ENaC channels to take up more sodium and reflex associated with hypokalemia. So whenever there is hypertension and metabolic alkalosis, think about aldosterone related causes if the patient is hypertensive for sure. If the patient is normotensive, usually in this kind of a setting only one important cause is there. In fact, 2-3 you can tell. The one important cause is severe hypokalemia. So if you take the physiology textbooks, if you take Guyton or you take Genong today, if you have any doubts, you can go there and see in Genong or Guyton, whenever there is a severe hypokalemia can maintain metabolic alkalosis. That's what they would have given. So what do you mean by the term hypokalemia maintains metabolic alkalosis, severe hypokalemia? The reason is because when you take a proximal convoluted tubule, let us go back because I'm very tired to draw the diagram again. If you go back to the previous image, whenever there is a hypokalemia, when you have a very much low potassium, that will induce a sort of something called an intracellular acidosis. That's what, because potassium and H+ are in constant equilibrium with each other. Potassium and H+ are in constant equilibrium with each other. Just hold on.